Hi, everyone. My name is E. David Crawford from the University of California in San Diego, and welcome to our PET tumor board. PET imaging, especially PSMA PET, in my opinion, is one of the most significant advances in prostate cancer management in the last decade. It has created a lot of opportunities and also challenges. I have observed that in many tumor or second opinion boards, almost half of the cases now are focused around PET scanning, particularly PSMA PET. We recently published our latest RaDaR 6 and 7 guidelines, which goes through in detail a lot of the indications for PET, the pitfalls and the ups and downs. We have a lot to learn, and we hope that these monthly tumor boards will broaden your knowledge in this area. I would like to thank Blue Earth Diagnostics, who recently developed and launched a PSMA PET product called rhPSMA or POSLUMA for this educational grant. We have gathered for this tumor board panel 3 international experts in this field. They have not seen these cases beforehand, and so they are as blinded as you are to what's going to happen in these cases. First panel member is Dr. Phil Koo. Phil is at MD Anderson Banner in Phoenix, Arizona. He is a nuclear medicine physician. Also, Dr. Daniel Petrolak, a medical oncologist from Yale, well known in the field of prostate cancer, is joining us. And a radiation oncologist, Dr. Paul Nguyen, from Harvard Brigham in Boston, Massachusetts. So, gentlemen, let's go ahead and get started. This case is a 60-year-old lawyer who had a PSA of 10.5. And he had a biopsy and had a Gleason 7 and half of the course, 6 to 12, primarily on the left. Conventional imaging was negative, and he chose, we have a proton center here, in 2020 to receive proton therapy and 6 months of ADT. Let me ask Phil to begin with. What's sort of the cutoff where conventional imaging is still indicated? Or with this guy, I mean, according to our RaDaR guidelines we did, he would have qualified for conventional imaging because his PSA was above 10. But he didn't have a nodule, and he did have a Gleason. He didn't have a, well, he didn't have an 8, 9, or 10, but he had a 7. Phil?
You know, in our RaDaR article, the first one, we talked about having 2 out of 3 criteria, PSA greater than 10, T3B disease, or Gleason greater than equal to 7. I think, you know, when we first wrote RaDaR 1, we didn't have access to PSMA PET. Now that we have PSMA PET, what we're seeing and what all the approvals are for unfavorable, intermediate, or worse disease. So we're seeing more and more use of PSMA PET up front without getting conventional imaging first.
Okay. So it's just let's just talk about some stuff here. Great group. Paul, the radiation oncology catching on to the grade group 1 through 5, or are we still in the Gleason 3, 4, and 3, 3 in that era?
I mean, I admit I still use both of them. I still liked seeing 4+3 like this, but I can, you know, translate it to grade group 3. With his 4+3 and PSA above 10, he's in the unfavorable intermediate group.
Dan?
Yeah, I mean, I think that we use both our institutions, so it just gives me a little bit more feel for what's going on.
All right, so let me just start. What about MTI? Phil, is this one of the indications is the high-risk local disease, whatever that means? This guy meet it?
Yeah, unfavorable intermediate it is a recommendation to get PSMA PET. And again, you don't necessarily need to get conventional imaging first. In fact, you shouldn't.
So we did, I mean, 2020 was sort of a transition year where we're beginning to get that, but today, without question, you would say get PSMA PET?
Yes.
Okay. And what about you, Paul? Would you radiate this guy without getting that? Or, I mean, we have some problems with insurance coverage too, but.
It's a tough call. For me, certainly for high risk, we're trying to get the PSMA PETs. Availability is an issue sometimes. Sometimes we have to wait 6 weeks for them. So this is a patient where I'm kind of plus minus. I would be willing to radiate him without a PSMA PET, but I would prefer to have one if I could.
Okay. And then I guess the other thing is this guy, 6 months of ADT. Dan, is that good for you or?
Yeah, I think also that's why I would like to see a PSMA PET. If I'm going to see occult nodal disease, I'm going to probably add to both length as well as the intensity of the ADT. It probably would add a next generation to it. Although there's no data for it, but you would assume that this is potentially, micrometastatic, and that we'd want more therapy in the situation.
So what does ADT mean to you? I mean, does that doublet therapy? Is it, something for flare? What does it mean to you?
So, I mean, ADT in my mind is just simply single therapy. Doublet therapy would be ADT plus a next generation, and triplet, of course, would be adding chemotherapy to that. So, and I think we need a little bit more of a standardized term because ADT is a bit of a vestige, but again, I think we have to be clear with our definitions.
So we have doublet there. We had the first and second generation anti-androgens. Now we're in the third, and they still call them the second. But and we use the word ADT, and we have androgen biosynthesis inhibitors and other things, and that stands for androgen deprivation therapy. And people are talking about some other terminology. I think, and just writing a paper on this, is that we ought to keep the word ADT and just make it androgen directed therapy. So we're doing something to androgens, and I think that could be widely accepted without getting rid of our ADT term. But other people want to use ADT plus this and that. I don't know. What do you think?
I mean, I think again, if it's used consistently, it's not a problem. But as we saw with the terms hormone resistant, castration resistant, and then you and I came up with the term endocrine resistant years ago. We just have to be careful about our definitions that we're talking the same language.
Well, you and I wrote a paper about not doing that, and you know what? We were right now. Everybody's going back to what we said 10 years ago
Exactly.
about that when that came out. Okay. Let's get going on this case. So his nadir PSA is 0.9. Paul, not good. Good. What?
Not good if he got 6 months of ADT. I mean, I would expect these patients to be well below 0.1, undetectable after radiation and 6 months of ADT.
So he had double trouble. He was having a lot of hot flashes and was sexually active, but he got his doctor to start him on testosterone replacement therapy for 2.5 months. And he subsequently stopped it. He had pain with orgasm and other things like that. But after that, the following year, his PSA was now in May of 22, 1.23. He was in the clinic with clot retention. He had a bladder neck contracture, which was opened, and he had abnormal suspicious areas in his trigone, which were biopsied and determined to be radiation cystitis. He had another episode of retention. Here's his pathologic diagnosis from his biopsies. He had necrosis and he had inflammation. And down here, they say pathologic changes are likely due to radiation. So what do we, radiation oncologist, Paul, what do we do about this guy here?
Yeah, this is a tough situation. You know, we try our best to minimize the dose of the bladder, and we try all this daily imaging, but these kinds of things can happen. And it looks like this patient's had a particularly strong late reaction to the radiation. So, you know, at this point, we're trying to do supportive care. If he's bleeding, we send them to our urology colleagues and see if there's anything that can be fulgurated or, you know, any way to create hemostasis. And then otherwise, we're trying to let them heal. And so that could be observation, that could be all the way up to sending them for hyperbaric oxygen.
Okay, well, you're right on. So this guy also went to Duke and worked there also. And then in November of 22, he got hyperbaric oxygen plus Cipro, and he had gross hematuria GH with burning for a while, got a little bit better. And now we see him with a PSA of 8.32. Phil, imaging, what do we do?
You know, it's interesting. Earlier on, when he went up to 1.23, I probably wouldn't have imaged him. But now that it's rising, and it's rising pretty rapidly, I'm getting a little concerned and would definitely want to be aggressive. This seems faster than I would have expected. So I think a PSMA PET here should be considered.
Okay. Anybody disagree?
Nope.
All right. So what happened was he ended up getting imaging, and the first thing he got was MR of the prostate, 48.2 grams. That's kind of large for a guy that's got ADT and radiation, but he had, you can read it here, decreased signal, seminal vesicles, I guess. How hard is a MR to read after radiation, Phil?
I mean, I don't read prostate MRs, but from what I know and speaking to colleagues, I think it is challenging, and it's oftentimes difficult to separate inflammation from tumor.
Okay. Well, he had a bone scan and no definitive evidence of osseous metastatic disease. And that was it. And we had this was a guy that we got a lot of pushback from insurance companies about getting a scan and availability of some of the new PSMA scans. So we were able to get a fluciclovine oxymin scan on him, and I need to go back here. And you can see he had activity in his prostate gland, and so it had some nodes. What do you think of sub-centimeter bilateral retroperitoneal on left pelvic nodes, Phil?
You know, the fact that they're sub-centimeter to me is irrelevant. If they were fluciclovine avid in the setting of an elevated PSA, I would be very concerned those were sites of metastatic disease. It's interesting, you know, they commented in the impression about these bilateral inguinal nodes. We know that prostate cancer rarely goes bilateral inguinal, but they're commented here, so I wouldn't worry about them. But it's really those retroperitoneal nodes that concern me. And I'd also like to point out that MRI, I read the impression there, you know, it's challenging because the MRI is just looking at the pelvis, and you could see that these nodes that were outside of the pelvis, potentially in the retroperitoneum, would not be called. And even if it was in the field of view, they may have not called it because they were sub-centimeter. Because on MRI and CT, we often use CT as the cutoff, or we use size as a cutoff, not physiology.
Okay, so I like the biopsy prostate. So I did that on March the 8th of this year, and didn't find anything but radiation changes. And our tumor board said radiate lesion, whatever that was, some of them, and start ADT. Dan, would you at this point start ADT or not?
Yeah, I mean, based upon these small lesions, small lymph nodes, I would definitely start ADT.
Okay. And so you would treat him like metastatic disease, right?
Yeah, I mean, I think again, I'm pretty convinced from the data, and I agree completely with what Phil said before about the avidity of these particular areas.
So what does ADT mean to you in this guy? Are we talking about his LHRH agonist or antagonist?
That's a great question. I would give him an LHRH plus the next generation.
Okay, so like apalutamide, enzalutamide, darolutamide,
Exactly.
something like that. You wouldn't give chemo in this guy, right?
No.
Okay. Paul, what would you do to him? Is there anything you'd radiate here?
Yeah, I mean, it sounds to me like he still has potentially quote unquote curable disease in the extent that he's got the nodes in the pelvic region and the retroperitoneal. It's a little bit higher than I like to go, but he's a young man. I think you said he was 60 initially. So I would try to radiate a nodal region, like basically try to patch on retroperitoneal pelvic nodal field. Try not to overlap with the prior proton field, and try to stay off of his bladder, because obviously his bladder is very sensitive right now.
Yeah. Bill, is there any reason to get a PSMA scan on him or anything at this point?
At this point,
You know,
I don't think so. I don't think it would necessarily change what we're doing. And to your point earlier about actionable findings, I don't know if it would necessarily change anything right now.
Okay. Well, I try to get one, and PSMA scan right in May or June, and when it was unable to get it, kept being persistent, and we got one, and so it was an interesting one of the conversations. I remember being on the phone for 20 minutes talking to various people about trying to get approval, and then getting passed to the next one and next one, and then I got disconnected. So that, I don't know if anybody else has experienced that harassment, but it happened. So I was able to get a scan on him, and this is what it showed, Phil. It showed that he has multiple foci of increased uptake within the gland. Biopsy proven cancer that I missed, or something when we did it. I didn't do 12 core biopsies, and again, uptake in left external iliac, suspicious multiple retroperitoneal nodes, increased PSMA uptake. So they think it's probably it is probably metastatic disease. Do you feel comfortable calling it that, or?
You know, I would like to see the images here. It's interesting. You know, the first impression talks about the prostate gland, but that was biopsied and it was shown to be, inflammation. And I think this is a good example how just because it has uptake with PSMA doesn't make it prostate cancer, and inflammation can have increased activity. The second impression, that makes sense. I think they point out something that we should all be aware of, that ganglia can have uptake with PSMA. I imagine if we looked at the CT images closely, hopefully we could identify lymph nodes actually rather than ganglia that are concentrating the radiotracer. So based on this, and we also have the Axelman results, I think would feel pretty comfortable that those lymph nodes are metastatic.
So our group thought that this is this probably, I mean, with this PSA level being what it is, and that ADT and third generation anti-androgens should be started, and that's the direction we're going. Does anybody disagree with that? Dan?
Absolutely not. Great. Exactly what I would do.
Well, I want to thank you all for looking at this case. As you know, we see a lot of different cases now, and then a whole change in the environment with molecular targeted imaging, and I think we have to really be on our toes to sort of know what to deal with these people. So again, thank you all, and we'll see you for next month for our next case. Thank you.